Thanks for joining us for the next in our series of In Conversation With. This time I'm speaking with Dr. Cindy Chow from the Southern Maine Health Center in the US. Cindy's been a long-time user of Magseed for both lesion localization and the marking of axillary lymph nodes. But it's her more recent adoption of Magtrace that I wanted to focus on. In fact, today's discussion is all about her first case, and she chose quite a tricky one. We have a 67-year-old woman with a triple-negative breast cancer who had recently completed a course of neoadjuvant chemotherapy. The patient had a previously positive lymph node that was marked with Magseed. And intraoperatively, as well as Magtrace, we asked Cindy to also inject her existing standard of care of technetium and blue dye. This allows us an inpatient comparator to show just how well the magnetic technique is working. I think you'll find the results quite interesting. We certainly were pleased that because of the magnetic technique, the patient was able to avoid an axillary lymph node dissection. Well, thanks for joining us, Cindy. I know you're busy, so I don't want to keep you too long, but if we just get straight into it, I wonder if you could take us through that first case that you had with Magtrace.
So I don't remember how old she was. She's in her 60s. Not the healthiest patient, but she had a triple negative breast cancer and started with her chemo. Not the most compliant patient. So we got her through probably about 2/3 of her chemo and then just decided we would just get the surgery over and then kind of figure out how to finish the rest of her chemo. But she'd had a great response based on her imaging to the chemotherapy. It looked like the nodes had pretty much gotten back to normal. So I was very excited to try to do the sentinel node technique with her because then she doesn't need a dissection. So she did have a positive node, which was clipped before her chemotherapy started. I've done a second case where I injected the days before with no EMLA or anything, and the patient did completely fine. So even though I didn't really trust Paul when he said, "Oh yeah, you can do it and it won't hurt," it really is true. They don't feel it. It doesn't bother them. Nothing like the technetium.
Right.
So I agreed to do pre-op because she was going to get EMLA for her technetium. And I thought, well, I'll just kind of tag along after that. So before we went into surgery, about 30 minutes, she got her technetium injection. The EMLA was taken off. And then right after the technetium, I did the 5 mLs of lidocaine subareolar. She didn't feel it. I waited the 1 minute-ish, just the time from injecting the lido to turning around and drawing up my Magtrace was probably sufficient time because when I injected it, she had no problems. She kept talking right through it. Didn't feel it. So we did that and it worked great. So we just did the mastectomy. It moved right on to the lymph nodes. The first node was the clipped node. So that was very easy. And that was interestingly very low counts with the isotope, and even the blue only had little bits of blue in it. But interesting, the node was, if this was the node, there was like brown here and blue there. It wasn't like mixed together. They were definitely the same node. I just thought it was interesting, and it was actually fascinating because I could see the brown and the blue, and they were very different colors. Some of the others were the mixed, where it's kind of that charcoal gray. Some people are doing the axillary reverse mapping. It's going to work great. You can definitely see the different colors. The blue is very different from the brown.
Yeah, that's interesting.
So anyway, so that first one was the seed, not very radioactive, and little tiny bits of blue. So I'm not really even sure I would have gotten a whole bunch of signal or even found it with just the isotope and the blue dye. And then after that, the next one was brown only, very radio. Let's see, the Magseed was 600 in vivo, 1000 ex vivo, Magtrace with no isotopes, and all the others had no radioactive tracer at all.
Okay.
And so number 2 had no blue either, so it was only Magtrace, and I could see the brown. Number 3 did have some blue, but wasn't radioactive. So those are very difficult to find if you can't. I mean, the reason we use the dual tracer is to use the isotope to get you close, and then the blue dye really kind of helps you speed up finding the node. But if it's just blue dye, with no isotope, it's extremely difficult to actually go through the entire axilla looking for anything blue. So I'm really not sure that number 3, even though there was blue in it, that I would have found it without the isotope. It had Magtrace, 2600 in vivo, 5400 ex vivo, and it was that charcoal gray with both the brown and the blue.
Yep.
And then the last one, even lower signal with the Magtrace, but once it was out, the signal was 1,000. It was only brown, not blue, and not radioactive. So
Right.
that one wouldn't have been picked up at all. And technically, you only need 3 when you're after neoadjuvant. So, but good that we got 4. She had a bad cancer.
Right. So if we were to split the nodes out by how they were found, the magnetic technique of Magtrace and Magseed, that would have found 4 nodes?
Yes.
Okay. And if we take the dual tracer, how many nodes did that find?
There's a possibility it would have picked up 2.
Okay. So whichever way we look at it, if you just had the dual tracer, this lady would have been having an axillary lymph node dissection.
She would have ended up with a dissection.
And you mentioned earlier that the patient didn't experience any pain. The difference now is you're injecting while the patient is awake. Do you put that down to where are you injecting, whether it was a peritumoral injection or subareolar injection or something else?
I'm not sure. So she did not have a nipple areolar complex. So,
Okay.
But I suspect even if she did, it really wouldn't be painful.
Okay.
I mean, I don't think that the amount of lidocaine, certainly the EMLA, it only numbs the surface, so it doesn't really numb underneath. So the amount of lidocaine that I did on my first patient, I mean, that's a true reaction. The EMLA wouldn't have numbed that, and she truly didn't turn a hair.
Well, that's great that you're getting results that we would expect. Actually, injection pain is down to the tonicity of what's being injected. So technetium, something that's well documented to be extremely painful, sometimes described as being the most painful part of the whole procedure, is hypertonic, whereas Magtrace is hypotonic, and largely to believe to be why injecting patients awake with Magtrace, they don't feel any pain at all.
Yeah, the patient was just like the one that I did in clinic was like, are we done? She also had a little splinter in her finger, and she said that hurt more because, I mean, I just numbed it so that I could dig out the splinter, and she's like, that was way worse.
Just switching subjects slightly, I want to get your thoughts on delayed sentinel lymph node biopsy. What do you think of the technique, and have you had a chance to do one yet?
I have not, but this is one of the major reasons that I was interested in Magtrace, and now the neoadjuvant has piqued my interest just as much. But it's a huge disservice to our DCIS and prophylactic patients DCIS, pretty much everyone in the world will do a sentinel node. So their lymphedema risk is, 3%. It's not great, but when they get it, it's they have it. So if we can do their surgery and hold off on the nodes and only do it for people that really need it with the invasive cancers, that's like I said in my message, it's a game changer. It changes how everybody thinks. I think Chip Cody may be one of the few academic places that really consistently does sentinel nodes with prophylactic mastectomies, because that rate of getting an invasive cancer with negative MRI is really low. It's maybe 1%. I mean, it's there. You do see it, but it's really low.
Yeah.
So the risk of lymphedema of 3% versus a 1% chance of finding some invasive cancer, to me, the numbers don't add up, but it's true. If you have to go back and do a dissection on a DCIS, that's even worse. But then people have been fiddling around with, injecting the technetium in the flap and the blue dye in the flap or something like that to still get a sentinel node. But this is even better. You don't have to do anything.
Well, thanks for taking the time in what is a very busy day. It was great to discuss your first Magtrace patient. And thanks for all of your time and insight.
Thanks. Nice to see you, Matthew. Maybe I'll see you at one of the meetings if we ever start having meetings again.
Absolutely. I look forward to catching up face to face when everything is back to normal.
Sounds good.
Thanks again.